Good morning, friends. I am Dr. Captain D.K. Ramawat, consultant non-invasive cardiologist working at Ramawat Heart and General Medicine Hospital, Barmer, Rajasthan, India. Today, we are taking a very interesting topic, the trifurcation and quadrifurcation, left main coronary artery, percutaneous coronary interventions, challenges and strategies with tips and tricks. Here the most important thing is the left main coronary artery bifurcation. In 2/3 of the patients, the LMC bifurcates into the left anterior descending and left circumflex artery. But in 1/3 of the patient, it trifurcates into the LAD, left circumflex, and ramus intermedius. So, how to do percutaneous coronary interventions in such a position? So, let us start trifurcation and quadrifurcation, left main coronary artery. So, welcome friends. This is trifurcation and quadrifurcation, left main coronary artery. Percutaneous coronary interventions, challenges and strategies with tips and tricks. So first we take the introduction. Approximately 5 to 10% of individuals undergoing coronary angiography have critical unprotected left main coronary artery stenosis. Now what is unprotected? Unprotected left main stenosis is a condition where the left coronary artery and left circumflex artery have no previous patent grafts. Now, for patients with LMCA disease, Serous demonstrated that revascularization with percutaneous coronary intervention is equally safe and effective as coronary artery bypass grafting. This is the important thing to note. Anatomically, LMCA is comprised of ostium, the mid and distal segments. Clinical markers of LMCA stenosis are what? Number 1, crescendo pattern of angina pectoris. Number 2, ECG. Number 3, ST segment depression with pain in the chest. And 4th, with concomitant anterior and inferior ST segment alterations. And the 5th and the last, fluoroscopic calcification of LMCA are all clinical markers of LMCA stenosis. These markers are not specific, and coronary angiography is the gold standard for investigation. I again repeat, these markers are not specific, and coronary angiography is the gold standard for investigation. The left main coronary artery supplies blood approximately 75 to 100% of the left ventricular cardiac mass. If LMCA disease lowers the blood flow to a major section of myocardium, thus putting the patient at great risk for life-threatening events such as left ventricular dysfunction, arrhythmias, with a high mortality rate reaching 50% of those managed medically. For many years, coronary artery bypass grafting, means CABG, was regarded as the gold standard therapy for unprotected LMCA, but now the things are changed. However, because to improved stent technology and improved operator experience and effective percutaneous coronary interventions have become more common in recent years. Due to technical, anatomical and physiological challenges involved with LMCA bifurcation and trifurcation lesions, integrated strategy involving particular stent strategies, for example, physiological and anatomical evolution and adjuvant pharmacological drugs should be coupled for a better clinical outcome. Now, we are going for comparison of percutaneous coronary intervention and coronary artery bypass graft for distal left main coronary artery stenosis. Now, observational studies are what? Some observational studies found that the early clinical events, including mortality between 30 days and 3 years of LMCA stenting, were comparable to or better than those of CABG due to significant increase in periprocedural myocardial infarction or stroke in CABG patients, while in PCI, on the other hand, had a greater chance of target vessel revascularization than CABG. Now, procedural factors to improve outcomes of left main coronary artery stenting are what? Number 1, intravascular ultrasound. IVUS provides accurate information about the stent sizing and aids in the detection of stent underexpansion as well as malapposition, making LMCA PCI safer and more effective. Intravenous ultrasound guided LMCA stenting is linked with lower mortality. Now, what is malapposition? Here, lack of contact between at least one stent strut and the underlying intimal surface of the vessel wall in a segment not overlying a side branch known as malapposition. Now, second point, percutaneous coronary intervention technique. Even with real bifurcation stenosis, the single stent procedure definitely outperforms the two stent technique in terms of long-term clinical results. Third, FFR, fractional flow reserve. Using FFR to guide treatment decisions for LMCA is associated with a better prognosis, and that the intermediate LMCA lesion with FFR 0.75 to 8.8 significant stenosis. 0.75 to 0.8 is significant stenosis in FFR might be safely postponed. This is important. Now, in addition, if FFR measurement is not possible for LMCA stenosis, then the IVUS minimum lumen area, that is less than 4.8 millimeter per square, might be utilized to define critical functional stenosis. One point more, you can see this figure here, that FFR, a man can understand better in this figure. Topmost is 1 and in the below is 0. So 1 has got no stenosis, means blood is flowing very fine, and 0 is total calcification. So from 1 to 0.75 is actually without stenosis, but after 1.75 stenosis starts, and up to 0 there is total calcification. Now, risk assessment score, combining syntax and the Euro score into a shared risk model. global risk classification. Procedural and long-term outcome was linked to a substantial improvement in predicting cardiac death in patients having PCI for LMCA. Now, stenting strategies. The choice of technique is dependent on vascular and lesion features. For example, first plaque distribution, second branch diameter, third angle, fourth side branch morphology, as well as the operator's expertization. Now, provisional stent strategy. Provisional is a one stent procedure that allows for the implantation of a second stent if necessary. For example, TN protrusion technique, TAP technique, second Culotti technique, and LMS bifurcation. You must remember, and it is very essential, that in 2/3 of the patient, the LMS bifurcates into the left antidescending artery and left circumflex artery, and while in 1/3 of the patient it trifurcates into the LAD, left circumflex, and ramus intermedius. For distal left main stenosis, stenting across the trifurcation towards left antidescending is performed. Then provisional stenting of left circumflex is performed. Lastly, ramus performed. Stenting done either with T stenting or Culotti technique. Post dilation with kissing balloon and proximal optimization technique, POT that is performed always on all procedures. Kissing balloon is a procedure that involves simultaneously inflating two balloons in a patient's main vessel and side branch to treat coronary bifurcation lesions. And POT, proximal optimization technique, is a post-dilation procedure that improves the result of stent scaffolding in coronary bifurcation lesions. The T and protrusion technique. When the main branch diameter is larger than the side branch and the angulation is less acute, about more than 70 degrees, the TAP, T and protrusion technique can be applied. Now, steps. What steps are there? Stenting one main branch with jailed guide wire on side branch. Here, jailed wire technique is one of the commonly used technique which is performed by inserting two guide wires into both the main and the side branch of a coronary artery. When the main branch is stented, the side branch wire is jailed between the stent and the wall of the proximal main branch. The technique is used in type B treatment and useful strategy for treating bifurcation lesions. Now, second step, proximal optimization technique, POT, using balloon with diameter of proximal main branch size positioned just at the side branch. It is a post-dilation procedure that's used to improve the result of coronary bifurcation stenting. Third, kissing on main branch and side branch after rewiring of side branch. Fourth step, stent placement on the side branch with uninflated balloon on main branch ready for final kissing balloon inflammation. It is a procedure that involves simultaneously inflating two balloons in a patient's main vessel and side branch to treat coronary bifurcation lesions. Fifth step, with the stent positioned to enable 1 to 2 millimeter of protrusion into the left main is done. Here is an example we give. I am giving you an example of such a case where TAP, TN protrusion technique was exercised. That is, a 50-year-old male diabetic with critical distal LMCA involving LAD, ramus and left circumflex, means trifurcation is there. We will see figure 1 to 8 afterwards. Now the steps, what are the steps in this? First step is femoral access done by 7 branch guide catheter, which is used for complex procedure, and the EBU medulonic catheter is a supported safe guide catheter used for LMCA, and all 3 branches wired. All 3 branches wired. Now pre-dilation done on LED and RAMS first. Then stent 3 into 28 deployed from mild LMCA to mid LMCA. Stent 3 into 28 deployed from mid LMCA to LED, and jailing wire in side branch. The jailed wire technique is one of the commonly used technique, which is the jailed wire technique, which is performed by inserting 2 guide wire into both main and side branches of a coronary artery. When the main branch is stented, the side branch wire is jailed between the stent and the wall of the proximal main branch. Now the ramus, ramus recrossed with cross IT 100 wire strut and vessel dilated towards side branch, keeping uninflated balloon in main branch. Strut is a ultra thin strut, is a drug eluting stent. Ultra thin struts is a drug eluting stent which may further improve the efficacy and safety profile of PCI by reducing the target vessel and target lesion. Here you can see world's first thin strut, fully dissolved stent developed in India. This is the size, and this is the actually figure, nature you can see of the strut. 5th point, side branch stent advanced and deployed, keeping 1 to 2 struts protruded into LED. Remember that struts in a stent are mass of wires. Struts are mass of wires that makes up the stent and thickness of the struts that impact stent performance. Now simultaneously kissing balloon inflation done on left main to LED and RAMS. The kissing balloon technique is a procedure that involves simultaneously inflating 2 balloons in a patient's main vessel and side branch to treat coronary bifurcation lesions. Fractional flow reserve evolution on left circumflex showed no critical lesion. Final result showed action result. I will show you 6. You see here figure 6. Fractional flow reserve on left circumflex negative. It is 0.93. 0.93 means there is no calcification. I have given the figure of FFR here in the corner. You can see here, and you can see the 0.93, and there is no in 0.93 there is no calcification. So this is the final result of that. Fractional flow reserve on left circumflex negative. And here the first figure shows critical distal left main coronary artery LMCA trifurcation. You can see that trifurcation is there. 1, 2 and 3. And in figure 2nd you can see deploying stent left main coronary artery to left anti-descending after stenting LED and RAMS and left circumflex. And in 3rd recrossing RAMS. And in 4th simultaneously kissing balloon after deploying stent in RAMS with minimum protrusion. And 5th, in 5th figure, proximal optimization technique, which is a pro-dilatation procedure that is used to improve the result of coronary bifurcation stenting. Here you can see in figure 6 the FFR is 0.93 and in figure FF 9.93 no calcification. So fraction flow reserve on left circumflex is negative. Hence there is excellent result. Final result showed excellent because FFR is 0.93. Here you can see the FFR and this is final result. In 7th figure you see schematic representation of T and protrusion strategy used to treat coronary bifurcation lesion. It is a modification of the provisional T stenting technique. And 8th, of course, final result showed excellent result. Now mini crust stenting. When the main branch diameter is larger than the side branch diameter and the angulation is acute, that is about less than 60 degrees, the mini crust technique can be applied. It is two-stent strategy used in PCI to manage bifurcation lesions. In mini crust technique, the stent in the side branch is positioned extending just 1 to 2 millimeter in main branch and is subsequently crushed with a balloon positioned in main branch prior to side branch stent deployment. Remember it. This technique was introduced in 2004 to fully cover the ostial side branch. Yes, a stent can be crushed. Yes, a stent can be crushed as part of a stenting technique called the crust technique. What are the steps in it? Number 1, all branches wired. The side branch is stented first with the stent positioned to enable 1 to 2 millimeter of protrusion into main branch, keeping uninflated balloon in main branch. Second, third, the side branch stent balloon withdrawn little into main branch and inflated further. Fourth, wire and stent balloon removed and side branch stent crushed by balloon in main branch. Fifth, main branch stent deployed. Sixth, proximal optimization technique POT done. POT is post dilation procedure that's used to improve the result of coronary bifurcation stenting. Seventh, side branch recrossed with wire. Eighth, final kissing balloon deployed on side branch and main branch. Kissing balloon inflammation consists of the simultaneous inflammation of the two balloons in both the main vessel and the side branch. Then report proximal optimization technique considered. Here is the example of such case wherein FFR revealed critical lesion in left circumflex. So there is a 78 years old diabetic male with stress test positive with critical distal LMCA trifurcation stenosis revealed on CAG, means coronary angiography. Now mini crust strategy used with the excellent result. Steps what? Steps are here. Number 1, a 7 sheath and 7 guide catheter which is used for the complex procedure, and EBU medrotonic catheter is a supportive shape guide catheter used for LMCA. Here all 3 branches wired. Secondly, functional flow reserve in left circumflex showed critical stenosis where FFR was 0.76, confirmed similar on intravenous ultrasonography also. Predilation done to LED, ramus and left circumflex. Now 4th step, first stent deployed in LED as the first side branch with minimal protrusion and crust, followed by same the ramus. Remember, a stent can be crushed as a part of crust stenting technique, which is a modified T-stenting technique used to treat bifurcation lesions in coronary arteries. Left main coronary artery to left circumflex stent deployed. POT, proximal optimization technique, done at LAD ostium, then recrossed. Second POT at ramus ostium done and recrossed. First kiss done at left circumflex to ramus and followed by second kiss LAD to left circumflex. The kissing balloon technique is a procedure that involves simultaneously inflating two balloons in a patient's main vessel and side branch to treat coronary bifurcation lesions. Report, proximal optimization technique done. Then final angiography showed the excellent results. I will show you. High pressure deployment help favorable outcome even in the case of high bleeding risk. Means patients where dual antiplatelet therapy has to be changed to single antiplatelet therapy. Here you can see the critical left main coronary trifurcation, first, second, third, and intravenous ultrasound also showing critical lesion on left anterior descending and left circumflex. So what happened here? In this case, fractional flow went to 0.76 and 0.76 you can see here is there is ischemia in this case. Just a minute. In this trifurcation, the FFR was 0.76, means there was calcification, and in figure second, after wiring three branches, left circumflex main branch and second left anti-descending branch and third ramus considered side branch and LAD stent deployed and crushed in a coronary artery bifurcation to cover the ostial side branch. So all three stents deployed and first side branch left anterior descending, second side branch ramus main branch and third side branch left circumflex. Now POT1 up to LAD and rewired, POT2 up to ramus and rewired, POT then ramus intermedius. It occurs, you remember this thing, it is very important. Ramus intermedius occurs in 37% of general population, is considered a normal variant. It lies between the LAD and circumflex, left circumflex, and originates from the end of the LMCA. So lastly, here this ramus was rewired. Now you can see here, first kiss left circumflex and ramus, kissing balloon inflation consists of the simultaneous inflation of the two balloons in both the main vessel and side branch. And in figure 15, second kiss left anti-descending and left circumflex. And in figure 16, the result after the first kiss. And in figure 17, schematic representation of the two mini crusts, a procedure used to treat bifurcation and trifurcation coronary lesion. With double kissing, left anti-descending and left circumflex. And figure 18, final result showed the excellent result. You can see. Here all the vessels are clear. And 19 fully exposed stents, fully expanded stents. Now double kissing crush stenting. Double kissing crush technique is a procedure for treating complex coronary bifurcation lesions. DK crush technique is associated with a lower rate of clinical events than other stenting techniques. The DK crush technique was developed by Zhang and Chan and first described in 2005. This is another bifurcation strategy which can be applied for trifurcation lesion, wherein the side branch is stented first, followed by crushing the balloon in the main branch, then recrossing side branch through crushed part and performing first kiss. Then main branch stem is deployed, followed by proximal optimization technique. Then side branch is recrossed and then sequential second kiss is done. Now I tell you about quadrifurcation. If left main coronary artery quadrifurcation lesions and their interventions has to be done, then remember data is scarce. We don't have much data about it. Data is scarce for this subset. And anecdotal case reports are available. Anecdotal means what? A personal experience or a story that is used to support a claim or draw a conclusion. Now, finally CABG are still preferred in this subset over PCI owing to huge amount of myocardium at jeopardy and technical consideration. Provisional and test techniques are employed for this subset is available in literature. And the last but not the least, the conclusion. Left main coronary artery trifurcates. All lesions are responsible for large amount of myocardial perfusion mismatch. Left main coronary artery trifurcate or lesions are responsible for large amount of myocardium perfusion mismatch. Left main coronary artery intervention, CABG as well as PCI are associated with a significant risk of adverse events. In PCI subset, which is mostly due to high rate of target lesion revascularization, and in CABG subset, which is due to cerebrovascular accident. The number of stents implanted and the criticality of lesions predicted a high combined endpoint of death, non-fatal MI and TLR, target lesion revascularization. Improved technique, stent design, adjuvant medical management including imaging modalities such as IUS and optical coherence tomography and physiological evaluation like FFR guided interventions are likely to improve PCI outcome in this group. The routine, provisional and dedicated bifurcation stent strategies for treating an unprotected trifurcation LMCA lesion is feasible. Stent strategies for trifurcation lesions are essentially the modification of bifurcation strategies. Sequential provisional stent strategies, that is TAP, TN perfusion and Culoti, and sequential crush technique like mini crush and DK crush are preferred methods respectively.